what do women actually want? They want you to say something small to them that's actually personal to them. It could be, take a dry biscuit in the morning. It could be, just get into this position, or just help with this sciatica. So with all the Birthlight moves, you can actually, even in a very small confined space, you can actually help people that come in from everything, from headaches. These lovely ladies do not want to get off the chairs. When you actually talk to them, it's you that gets off the chair that gets very excited and starts talking about this is what you can do. You can get down onto a cat and do things for sciatica, for lower back pain. And most of the rooms that you do antenatal consultations in are usually quite small. So you actually have to adapt all your moves into those smaller spaces, but these can be done. So you can actually teach your colleagues antenatally how to deal with some of the common complaints of pregnancy that you actually see in an antenatal consultation. And most of the couches that you have in a doctor's surgeries, or whether or not you're actually working in a hospital, they've usually got a couple of steps that go up to those couches. Those steps are really useful to actually show the ladies how to do lunges. So if we're going to be doing lunges on how to rotate a baby from a posterior to an anterior position, you use your lunges. The girls always know that I like the step that's got 2 steps. So if everybody says, where's those 2 steps? They go, oh, Gaddens has got them, because she always nicks those 2 steps. And that's purely because the higher your foot goes, the wider your pelvis will go. And it's like everything. If I actually can show a woman how she can actually open her pelvis during labour, and she can physically feel that difference, she's going to be more likely to do that. So we do lots of lunges, and this is rotating the baby from the right side or the left-hand side, of course depending on what side the baby's back is. We do lots of breathing movements as well. We do lots of Ujjayi, because Ujjayi increases natural oxytocin. And we also can talk to them how to increase their own natural oxytocin. One of my little bugbears at the moment is our induction of labours. So in the UK and in New Zealand, I work on the induction wards, and I also work on triage. So I have felt so many unripe cervixes. It's like, where is the cervix? It's up there somewhere. And we're expecting these poor ladies to actually be induced with something either like Propes or Prostin. And the doctors, and also the women as well, they actually want to be induced from as early as 36 weeks gestation, and the cervix isn't ready, the mum's not ready, and the baby isn't ready to come. So we're actually starting off, we were talking about cascades and interventions, we're actually starting these inductions off with the mum not being prepared and the baby not being prepared. Michelle O'Donnell talks about the old hormones. I love it, if I could, I need Francois to say this, the little cocktail of and he talks about this lovely cocktail, and we don't actually allow these women to have this lovely cocktail that actually starts from around about 36 weeks onwards. But we actually have to look at why we're doing all these inductions. And the unit that I work in, as you can see, that our rates are increasing, really a very small amount, but they're increasing all the time. So our induction rates are increasing, our caesarean section rates are sometimes static, but usually they're increasing. And it's not, I was speaking to one of the midwives who does the VBAC clinic, and she was saying that our numbers actually increasing on second time around caesareans, not necessarily emergency sections, but our second time around. And I do antenatal clinic as well. I'm a bit of a jack of all trades, I go all over the place. And when we do the bookings for elective caesareans, invariably it's for previous caesarean section. So the woman has already had one caesarean. Once we've actually had that one section, then you've got other problems, and once that actually cascade starts going. And so they're frightened already. And so what the classes will actually do is actually try and cope with that fear factor. It's like everything. If you're more aware of what your body is supposed to do, then you're going to be less fearful. If the classes give you that education, and it will do, and those ladies that have done my course, I know Lisa's here, and she's just done my course in London, is I always work with my dom and pelvis all the time. I've got a very lovely flexible pelvis, and it's with this that I work all the time. And in your classes, you can actually work with your dom and pelvis. I work with lots of other props as well. I like my belly dancing skirts as well. So Jean Sutton actually came up with these words quite a few years ago, at least 10 years ago, about optimal fetal positioning. Some people say now, is that really necessary? I still say definitely yes, because you can actually feel when you palpate somebody whether or not that baby's head is flexed antenatally or not. And why are we going to wait until that woman actually goes into labour before we start looking at getting that baby adequately into the pelvis? So I see people at term plus 10. I saw quite a few ladies yesterday, I was working yesterday, and these babies are still deflexed. The head is still deflexed before it goes into the pelvis. And it won't go into the pelvis if it's deflexed, unless you've got a really big wide inlet. And then if you've got that, then you've got more chance that baby is going to be born as a posterior position, or even end up as an emergency section for a brow presentation. So we should look at, and this is another thing of my little bugbears really, why don't we actually look at all the women at 36 weeks approximately, those women I have to say that actually want to come, is that if the woman actually wants to try and birth as naturally as possible, and I always put that in inverted commas as well, is that we can actually work with this woman and give her more awareness from 36 weeks onwards. 36 weeks onwards, as you can see that I've written down, is really when all the maternal adaptations are happening. So we're not only are we looking at maternal adaptations, we're looking at fetal adaptations as well. We can talk to the woman about what's happening to her birthing hormones, how we can encourage natural oxytocin, and that's usually with massage. In Birthlight yoga, we say if we have a relaxed neck, we have a relaxed sacrum. And we're all trying to increase that love hormone. Lots of ladies at this point also start grinning at me. Well, it's the men actually that start grinning at me. And I go, well, you can if you want to, but that's certainly up to you. Most ladies go, no, they can't be asked, and the men always get very disappointed at me as well. So the other things that we can look at, of course, is the fetal influences as well. If you have a baby that's more well engaged into the pelvis, then that cervix is going to become much more forward when you actually do an internal examination. By actually that cervix coming forward, you're going to increase your natural estrogens, and it's your estrogens that are going to soften with prostaglandins the neck of the womb. So it's looking at both maternal and fetal adaptations. And we're also looking as well is if that baby has got a well-flexed head, how easily it's going to go into that pelvis, and how it can rotate a lot easier from a posterior to an anterior position. So Birthlight yoga, from a midwifery point of view, can be used in an antenatal consultation to actually get the woman more ready for all the things that are going to happen to her for once she actually gets into the hospital. And what I would always like to say is all the good work that you ladies do antenatally, does it actually benefit the woman, and does it actually happen when they actually go to whichever unit they're actually going to be birthing in? It makes a big difference to which unit they actually birth in. Is it going to be a small midwifery-led unit? Well, actually, in Cambridge, they haven't got a small midwifery-led unit, they've got a big midwifery-led unit. Is it going to be in a consultant unit? And with consultant units, you've got timelines, you've got lots of pressures, and it's not the pressures always from the women or from the babies, it's the pressures from your peer support, and it's the pressure from the registrar, we get the pressure from the consultant who's on, and I spend a lot of time standing next to consultants and registrars who are actually then making decisions on what we're going to do next with, say, a lady in labour. So all these things we can do actually antenatally before the woman actually hits whichever unit she's actually going to birth in. And then it's actually giving that more awareness and advice to the midwives. So I've been a midwife over 32 years now, and I am learning all the time. Now you could say that's a very interesting, and I like to say it's an interesting and exciting job, and it's definitely a career because my career keeps changing all the time. But you are actually learning all the time. And the women need to learn as well about themselves and about their pelvis. Everybody's pelvis in this room is always going to be slightly different, and it's actually knowing your pelvis when you go into labour. So if you know that if you lean forwards, the front of your pelvis opens up and your sitting bones open up, you're going to be more liable, especially if you're going to actually have a home birth, maybe think about birthing in that position. And you tend to find that your body will actually tell you what to do. So if I actually say to a woman in labour, how about if we try it like this? She may do it once, just to pacify me, just to say, oh okay, we'll give it a whirl. But when she starts to actually wanting to actually do an exhale push, is that she won't do it. She'll just go, no, get all grumpy with me and say, this is not what, no. And she doesn't even, and she, you know, if those ladies that have had labours, they'll go, no, no, and they'll get, I don't want to do it. I don't want to do it, Wayne, I want to move over. And you say, fine, just do whatever you want to do. But if you know that before you actually go into labour, you're going to be much more aware of how to actually birth spontaneously and how your body actually will just actually make you do that. If you actually stand back and allow a woman to stand forward, leaning forward, you're going to open up your pelvis by 28%. And I actually watch them, and their hips go one way, one hip goes one way, the heel of the other foot goes up the other way, and they start doing their own little twisting movements. And it's really amazing to watch. And it's quite a pleasure to watch because the ladies actually just do their own thing. So as a midwife, you're more sort of like, you're not in control. And that's what we want to try and do. Is your women who come, is they don't want the midwife to be in control. They actually want to do their own birth. And it's actually, as a midwife, allowing women to actually do what they know is correct for themselves and their own bodies. So the other thing that I'm going to just finish off with is, we've been saying this for quite a few years in Birthlight, and I truly believe that this will not change, it will not go forward until we have a government initiative. And it has to be a named government initiative. Because for some reason, if you have a named government initiative, or if it's known as a paper or something, this is like a big, it's like changing childbirth, you know, everything changes, we have this big major thing. So the most important thing would be for whichever midwifery organisation, whichever country you're actually working in, is for them to actually accept the Birthlight philosophy, and that actually adds to the midwifery curriculum. I teach midwives all the time. My doll and pelvis, I love it, it's with me all the time. And in the curriculum we do talk about pelvises and we talk about optimal fetal positioning, but certainly not in a lot of depth. So it's kind of, why are we actually going away from all the natural stuff? And it will come back in a big circle, but it has to be government-led. And that's what we're always going to be trying to look at, is for it to be government-led. So the Royal College of Midwives in the UK has actually accredited the course for maternity professionals. And also in New Zealand, I've actually got 15 elective educational points, which, believe you me, is quite a major thing to get. And I also teach the course in Australia, and we've got mid-plus points in Australia as well, and that's also, Francoise and I, we do a lot of emailing backwards and forwards across countries, and we always seem to be putting submissions for all different kind of things. And the other submission that we actually did recently was to teach in Prague. So the International Confederation of Midwives is in every 3 years. It's in Prague next year, and that's in June 2014. A lot of us, I was in New Zealand at the time, put a lot of accreditations forward. Lots of people tried to do it, and we got ours accredited. So Francoise and I are going across to Prague next year to do a workshop on Birthlight techniques, on actually how to open a pelvis as well, antenatally, but also during labour. And so everybody from New Zealand was a bit chuffed for me, because quite a few of them didn't get through, but we did. So it's actually with great pride I stand here as a midwife, and to say that I use Birthlight techniques on a daily basis. I use it antenatally when I'm a community midwife, I use it before inductions of labour, and I also use it during birth. And it also has been a life-changing event for me as well. And my 2 boys, Sam and Luke, big body boys of 25 and 27, both were born using Birthlight techniques. Lukey, the second one, was born underwater, 9 pounds, 7 1/4. And he was born with me flat on my sacrum, with my legs akimbo in a bath, because I was the first water birth in Northampton. And it's just saying, well, why is it I can do that? And why is it maybe somebody else can't birth a six-pound baby? It's actually knowing what each lady's actually got, and actually giving them the empowerment to actually birth and actually enjoy their actually birth.